It's just a huge honor for me today to be podcast interviewing Dr. Jeff Genecov, all the way from Dallas, Texas. He's a legendary orthodontist in my mind and many other people's minds. Seriously, it's just a huge honor that you're on the show today. Dr. Genecov has been practicing in the orthodontic fields for many years, and the enjoyment and thrill of achieving excellent results are always very exciting to him. He feels very fortunate to be able to help the people in his community gain confidence and self-esteem, as well as a smile they can be proud to show off. His commitment to patients goes beyond his dental education. It extends to everything that makes his patient experience comfortable and the results remarkable. He obtained his undergraduate degree from the University of Texas at Austin and continued on to Baylor College of Dentistry, where he earned his Doctorate of Dental Surgery and his master's degree in Orthodontics. He considers education a priority and now helps to teach the next generation of orthodontists and dentists as a clinical assistant professor in the Graduate Department of Orthodontics at Texas A&M University College of Dentistry. He is involved with several orthodontic study clubs that help him stay up to date with the newest technological advances in the field. He is also a member of many professional associations that keep him involved with the greater orthodontic and dental communities. Texas Association of Orthodontists past president, Greater Dallas Association of Orthodontists past president, International Craniofacial Institute orthodontic director, Alpha Omega Dental Fraternity Dallas chapter past president, Southwestern Society of Orthodontists board of directors, VP currently president-elect, American Board of Orthodontics diplomat, American Dental Association. It goes on and on. I could read it for the whole interview, all his list. Dr. Genecov has been chosen by his peers as one of D Magazine's best in Dallas and as a Texas Monthly Super Dentist, which were both incredible honors for him. As orthodontic director at the International Craniofacial Institute, he is one of the few orthodontists in the Dallas-Fort Worth Metroplex who has extensive experience in treating patients with cleft lip and palate and craniofacial anomalies. He was a volunteer faculty member at Southwestern Medical School for children with cleft lip and palate and facial deformities, as well as for the cardiovascular and bone regeneration research at the Children's Medical Center, and has lectured internationally in orthodontic treatment for patients with cleft lip and palate. Dr. Genecov has also started and sponsored a North Texas chapter of Smile for a Lifetime, a nonprofit in which Genecov Orthodontics provides orthodontic scholarships pro bono to 6 needy children a year. The program is in its 4th year of existence. He is an active triathlete, an Ironman, enjoys sports, hunting, fishing, reading, and music. He and his wife, Lisa, reside in Dallas with their children, Adam and Becca. The only bad thing about you, as being an Arizona Cardinals fan, I'm sure you're one of those Dallas Cowboy fans.
Born and bred.
Man, you guys got so lucky with that quarterback out of nowhere. You just thought that
the
franchise was over when Romo went down, and now this guy is better than Romo.
We were due.
Man, what an amazing quarterback. So what do you want to talk about? You could lecture on orthodontics for 40 days and 40 nights. Most of the people listening are general dentists. In fact, the data that I see, they're all general dentists. What did you want to talk about today?
Well, I think one of the things that we probably should touch on is the importance of early orthodontic visits for the kids, because it's started. The American Association of Orthodontics recommends that we see the kids starting at age 7, primarily for interceptive purposes. But I think it's important because oftentimes we catch impacted canines or ectopic teeth erupting that we can make things better when they're young. Do it in 2 stages or whatever it requires. But at the end of the day, if they wait until all the permanent teeth are in, sometimes you miss things that can cause patients to have significant root resorption or require extraction of permanent teeth that might not otherwise be necessary.
There seems to be a lot of controversial. Some people who are into functional appliance and things like that say they can grow a mandible if the child's looking class 3. And other people say the research really shows you're not really growing a mandible. Can you grow a mandible?
I don't think you can. I don't think you can make a mandible get bigger than it otherwise might get. I think you can take the interferences out that'll let it get as big as it possibly can. And I think that one of my classmates in my residency did a research study on the Herbst appliance 32 years ago. And the research study showed, if I'm not mistaken, that it's about 60%, it's close to 50-50 tooth movement and mandibular growth. What you can do, however, is you can make a difference in terms of a younger child sometimes with a real retrognathic mandible and improve the profile, improve the occlusion, and so forth, and you get there faster, but you don't ultimately get a bigger mandible than you otherwise would.
Same question on rapid palatal expanders. When you see a child and you recommend, you said age 7 is when you like to see them?
Right.
When you see a child at age 7, how many times do you look at there and say, I really want to use a rapid palatal expander and widen that maxillary arch, or not?
The one thing about my office, Howard, is that there's not a cookbook. Every child gets what they need. And so if a child has a buccal crossbite or a bilateral buccal crossbite or a functional shift as a result of it, then we'll definitely expand. If there's a question of crowding that we feel like we can, guide teeth in better and make it less likely for us to extract permanent teeth later on down the road by expanding at a young age, then we'll do that as well. But if it doesn't need it, then we don't do it.
When I got out of school in 1987, the big brands were already built of Colgate and Crest and Listerine and Oral-B and all that. But it seems like in the 30 years I've been a dentist, the biggest brand in all of dentistry built was probably Invisalign. And I was wondering, like 10 years ago or 20, when did you do your first Invisalign case, and what % of your practice is it now?
I did my first Invisalign case in 1999. So I was a fairly early adopter. And it's the percentage is definitely growing because as you've been in practice longer and longer, your practice population oftentimes changes. As you mature, so does everything else, and so we've got a lot more adults in our practice now, and that's a much bigger. They walk in asking for Invisalign a lot more often.
So, like, what % of your practice would you say it is now?
Oh, I don't know, maybe anywhere between 10 and 20%.
10 and 20. That's what most orthodontists all say, 10 to 20%. I would just think that I understand the cosmetics of it. They want clear, but I would think that you would lose a lot of control if it was some kid that's not compliant. I would think that'd be a lot of red flags.
Well, I was talking about the adults. I would say that the teenagers are probably fewer percentages than that. And I think the one thing that you have hanging over as a motivator, for lack of a better word, is if you put a teenager into Invisalign, and you say, if you don't wear the aligners like we ask you to, the other option is put braces on your teeth. And a lot of them, that's the last thing they want to do. So it's a pretty good motivator. To give you an example, I have a son and a daughter. My son is almost 26 now. My daughter's 23. And my son was a terrific Invisalign candidate. He did a great job. The things that we needed to do to for my daughter's orthodontics weren't really Invisalign related. So especially at that time, I wouldn't have tried Invisalign with that. So, and sometimes you have to do a combination treatment anyway. So it's something that we're always trying to improve and trying to increase, because I do think that within limits, Invisalign is going to be kind of the wave of the future.
Do you think that since we're the same age and you look so good and have all that hair is because you had 2 kids and I had 4?
I think there's a lot to that. Yep. I have a younger brother who's 5 years younger than me, and he has 4 children, and he has a whole lot more gray hair than I do.
I imagine. So, as an orthodontist, when you see general dentists doing Invisalign, are they usually doing it good, or are they usually doing okay, or do you see a lot, or is that kind of make you cringe a little bit?
That's a hard question to answer, Howard, because, those of us that have gone through orthodontic residencies and understand the biology of tooth movement and the time that we've spent trying to hone our craft, for lack of a better word, when you have somebody go to a one-day seminar at a hotel room and they come back saying, well, I'm going to tackle whatever's out there with Invisalign because Invisalign will do it for me, it kind of makes you say, well, are you really serving your patient the very best that you can by doing that? By the same token, there's no reason that some minor tooth alignment, some rotational control, things like that can't be done with aligners. But, as long as it's not more complex, then I don't see a problem with it. And even if I did, that cow's way out of the barn anyway. So there's how many dentists in the United States? 100,000, and how many orthodontists? Maybe 8. So you've got the Invisalign's marketing to the greater the greater population to try to, get as much market share as they possibly can.
Well, they've actually gone a step further, and now they're marketing direct to the consumer,
Right, right,
bypassing everybody. What was that
right.
company called?
Um, Smile Direct Club or something along those lines. Yeah.
Yeah. So have you? What do you think of do-it-yourself ortho now?
Well, I have to tell you that for me personally, and along with the American Association of Orthodontists, we're what's the word I'm looking for? Hesitant to recommend it.
Well, I would think it was kind of a gutsy move because since orthodontists probably do what percent of the Invisalign is done by orthodontists? Would you guess?
I don't think maybe 20%.
Really, you think so?
Yeah, yeah, I really do. I really think that I mean, based on what I can tell of looking at people's websites and things like that, I don't know the hard statistics, but I do think the large majority of Invisalign care is by general dentists now.
Huh, that is amazing. Dennis went through this when we started doing the bleaching in the 90s,
Right.
and then Crest said we're going direct. So yeah, we've seen this in the past, and we'll probably see it more in the future. There's a lot. I want you to first. I want to ask an extremist question because I'm embarrassed by some of my homies, some of the views they have, but moderation is the key to everything. And whenever you're an extremist, your elevator doesn't go to the top floor. There's a lot of general dentists who are just religious, adamantly against bicuspid extraction. And I know when I got out of school, it was twice as common as it is now. But to say that you don't believe in for bicuspid extraction, that's just not right. Would you agree or disagree with that statement?
I would agree with that statement. Do you want me to expound on it a little bit?
I do, because there's,
Okay.
whenever you have a tightly held religious view, you're not going to change it with the comment. They're just guys who say, well, when they pull a bicuspid, they're just looking at the teeth. They're not looking at the face. And then they dish in the face, and I'm an artist, and I'm looking at the whole face. I'm like, okay, I get that, but there are cases where you just cannot do it correctly.
And I agree with that. And my dad was an orthodontist for 50 years, and he used to say that, and this is round numbers, of course, but 25% of the time, if you take out teeth, you're committing malpractice. 25% of the time, if you don't take out teeth, you're committing malpractice. And the other 50% of the time, depending on how old the patients are when they start, how compliant they are, and what they want, what you and they want their final goal should be, you could probably treat them either way. So there's a lot of wiggle room there, and there's a lot of different. The seminar I was at this morning showed a number of cases that looked as if they could be extraction cases, and they were treated non-extraction. There's a lot more to it than just treating non-extraction. There's a lot of workarounds and experience and expertise that you have to try to treat some of these cases non-extraction. But I think in today's world, the trying to maintain the facial profile, lip support, and so forth, not just now, but when the patients are 30, 40, 50 years old, is certainly at the forefront of what we're trying to do. Having said that, there was an orthodontist that I respect tremendously named Jimmy Boley from the Richardson, which is another Dallas suburb, who also teaches on the faculty with me, and I've known him for as long as I've been in dentistry. When I was a resident, he had a continuing education class where he would take 100 photographs, lateral photographs of the face, frontal photographs of the face, smiling photographs of the face, and three-quarter photographs of the face, and he would say, tell me extraction or non-extraction. And no one could do better than a coin flip. No layperson, no orthodontist, no general practitioner could tell him which one he extracted and which ones he didn't extract on better than a 50-50 chance. So if you know what you're doing and you're good at your craft and you continually hone it and make it better, I think that you can understand orthodontics well enough to be able to not ever say you can't take out teeth, because clearly you can, and you can do a good job, and the patients can have big smiles and nice profiles. It just depends on the patient.
That reminds me of something I used to do in my seminars. I used to say, who's here with their spouse? Where's the husband and wives? And they'd raise up. And I'd say, okay, stand up, and then put your backs to each other. Okay, which one's a dentist? Raise your hand. Okay, tell me, is your wife's midline straight midline, or is it off to the right or the left? And it was a coin flip. And it's like, okay, so you're all freaked out when you're doing crown and bridge or veneers or a denture or ortho that the midline might be off, and you're a dentist and you don't even know where the midline is on your spouse. How could the midline be that important if it's a coin flip with dentists and their spouse and children?
And Tom Cruise did awful well for a really long time without worrying about his midline, didn't he?
Oh my God, that was amazing. I want to go to racial profiles. You know, when I was lecturing in Japan and Singapore, Malaysia, Indonesia, it was amazing at how many beautiful women were pulling their four bicuspids because they put their finger to their nose to their chin, and if their lip touched it, it was a bad thing, and they wanted to pull it back. Your lip is not supposed to touch the line between your nose and your chin. And then you come to America, and every woman's pumping their lip with Botox and all this crap to puff out their lips. So it really shows you beauty is just preference. I mean,
right, right. And I clearly think that there's extremes to either of those things, right? But somewhere in the middle is, you know, that under that bell curve can be a lot of different things, and culturally and racially and from continent to continent, even from country to country, you can see differences in what people believe are beautiful.
oh, absolutely, especially with gold. In all of Africa, Asia, and Latin American, girls see gold on their teeth as decorative, just like they do on their rings, fingers, ears, belly button, ankles, wedding rings. But then you come to the United States, and European descended women will not have gold in their mouth. But in my
Right.
practice, and you know, the Asians, the Africans, the Hispanics, they think it's pretty jewelry.
Well, just go to look at tattoos. Maybe I'm showing my age a little bit, but you know, who'd have ever thought that tattoos would be so popular?
Did you get one after you did your Iron Man?
I didn't. I have a rub on.
You know why I didn't get the Iron Man? I've done the Iron Man 3 times. How many times have you done it?
One so far. I've done a couple of halves, but only one full.
I did 3 in a row, but the reason I didn't, you know why I didn't get the Iron Man tattoo on?
Your wife didn't want you to?
I'm single, thank God. I paid $3.8 million for the right to be single. I say I don't have any tattoos because you don't see a bumper sticker on a Ferrari.
There you go. There you go.
The funny story about tattoos, I told my boys, no, I don't know where I got it, probably from my dad, that, you know, if I'm paying your college tuition when you're in college, if you do drugs or get a tattoo, you're on your own. And 2 of my boys, an hour after they left college, went and got tattoos.
Well, I told my kids the very same thing, and thank God neither one of them have done that. Done either. So,
well, maybe they might have
scared.
one that you can't see. There might be a
Yeah,
hidden one somewhere.
You never know. But
Hey,
I hope I never find out.
Speaking of your kids, so you're an orthodontist. Your father was an orthodontist. Do you think Adam or Becca will be an orthodontist?
No. Unfortunately, neither one of them are interested at all.
Is that because they're too smart, or they saw what it did to Dad and Grandpa and said, "I'm not going to do that to myself"?
I don't know. Adam and Becca both have much. You know, as dentists, our vision is about this big, right? Both
Right.
of my kids have really big worldviews. My son is a master's in science engineer at SpaceX right now, and he lives in LA. And my daughter works for the New York Nets. No, I'm sorry, the New York Knicks. She just left the Mets. Now she's with the Knicks in New York City. So
Wow.
their worldview is a lot bigger than mine was at the time I made that decision.
You know, I want to enter into the twilight zone now, the subject of TMJ. It seems like if you lined up 100 orthodontists and ask them ortho questions, they pretty much all agree on the most stuff. Same with endodontists, pediatric dentists. But man, when you enter TMJ, there's just camps all over the place. And
Right.
it's like, you know, it's like Methodists to Catholics to Hindus and to Muslims, and a 1 hour, 1 day course. Like my 2 older sisters became Catholic nuns right out of high school. I mean, they went straight from high school to the convent. I couldn't give them a 1 day seminar and make them a Lutheran, let alone a Hindu or a Buddhist or a Muslim. But a lot of people, a lot of general dentists, I've heard this told to the patient from my friends gazillions of times over 30 years. They say, when people have TMJ, they say, look, If I straighten out my arm, my elbow determines where my hand is. If I straighten out my leg, my knee determines where my foot is. But you know, when you bite down, your teeth determine where your joint's going to be. So the reason you're grinding your teeth and you have TMJs, your bites all off. So what I'm going to do is I'm going to do the ortho or send you to an orthodontist, and he's going to just let your jaws relax, do your braces, and when you're done, your teeth will be straight and your TMJ will be gone. What do you think of that explanation that I would guess is given 1,000 times a day in the United States of America? And by the way, you said there's 100,000 dentists. There's 211,000 licensed dentists in the United
There you
States.
go. Okay.
150,000 are general dentists who work 32 hours a week or more. But what do you
Okay.
think? What do you think of all these general dentists saying that orthodontics is going to correct your TMJ?
Well, it's better than them saying that orthodontics caused your TMJ.
You are an optimist. You see the world as the glass is half full.
So to answer your question, I think that there's some credibility to that. But there's a guy that I met on Dentaltown years ago named Jim Boyd, who, if you haven't interviewed, you probably should.
I've asked him like 10 times, and
he won't. Okay.
he won't do it. I don't know. I don't know if he's gone underground or if he. I don't know why. When's the last time you talked to Jim Boyd?
It's been a while. He came through Dallas a few years after we'd been corresponding a lot on Dentaltown, and we had a couple of drinks and had dinner together. And his perception of TMJ problems is that it's not what you have, it's what you do with what you have. So because we all know lots of people with horrible bites and big COCR slides, and they don't have a TMJ problem one because their constitution is set up to be more adaptable than those people that have those issues. So I think, and they're perfect people with perfect occlusions that have, TMJ problems because they've damaged the joint somehow down the line, and they don't have the constitution to be able to repair it. So I think if you can give somebody the most ideal occlusion possible, then you have a better chance, and CO and CR are coincident, then you have a better chance of solving the problems than if in somebody that's susceptible to TMJ problems, then I think you have a better chance of fixing it. By the same token, you can also do it with a piece of plastic and get them comfortable, and you don't have, you have that option as well.
Well, what the reality of TMJ, bruxism, grinding, clenching, abfractions in America, I would say it's the 80-20 rule. 80% of the dentists just take an upper alginate and make a night guard for the upper.
Right.
And then you have another 20% that, do everything from A to Z. What do you think of the average mean mode mu general dentist? You're grinding, you're clenching, I see abfractions, I see some, I'm just going to take an upper alginate and make you a night guard.
Well, I think that if you take an upper alginate and make a night guard and don't adjust it correctly, then you're not doing the patient a real big service. In fact, I had a lady come in the office just last week where she'd had a dentist do that, and he didn't educate her about what it would do to her bite when she woke up in the morning, and he didn't educate her about how her teeth were going to feel until things settled back down during the day. And he didn't adjust it after he put it in. He just gave it to her. So after about 2 weeks of sleep in it, she said, "This is for the birds, man. I'm done." And she put it in her drawer, and she stopped using it. And then as things got worse, she finally figured out that she wanted to try something different. So she came to see us the other day, and I adjusted some interferences off the hello kitty. I adjusted some interferences off, balancing interferences and working interferences and protrusive interferences off the splint. And not only did the pain go away immediately, so did the big pop she had in one joint. So I think that about 80% of the time, like you were talking about, you can put something in there and not even adjust it, and it'll probably work better because you're opening up the vertical dimension and you're giving some more joint space. And as long as you're not distracting the joint out too far, you're probably going to be okay.
What did you think of Jim Boyd's NTI? Because some people said, well, if you wear that a lot, the posterior teeth are going to super erupt, and that's going to throw off the bite.
Well, I think that if you wear it more than just sleeping time, yeah, it will. I think if you just wear it while you're sleeping, it won't. I have seen patients, and I have treated patients who have had NTIs that it did intrude the anterior teeth because they wore it more than they were supposed to. But for that reason, when I do make somebody an NTI, or the posterior teeth had super erupted, but when I make somebody an NTI, I always make it with posterior coverage, and that way, to protect the posterior teeth from super erupting. But I also tell them you're only supposed to wear this while you're sleeping.
Some of the should we call them more militant TMJ camps do not like orthodontics because they say it blows out the curve of speed, the curve of Wilson, takes them from canine guidance to group function, and they just, just it does so many things that's against their core belief system of occlusion.
Well, I think that they have reasons to believe what they believe, but I don't think that it's 100%. And I think that they have to take, again, each case on an individual basis. You can have some particular tenets that are going to work, but if you don't have somebody that's an excessive bruxer or an excessive clencher, then if they're in group function, they may or may not have problems. I mean, how many people do you know when you were making? I don't know how many dentures you make these days, but didn't they teach us to do dentures in group function?
Right.
So did all those patients have TMJ problems?
No.
So I mean, so I don't know. I don't know the answer, but I do know that saying that orthodontics causes TMJ problems is just as on far to one side as saying orthodontics cures all TMJ problems.
If I told you my, I got a story to tell you about. So I got a friend that's local near me, and panky guy, articulator, face bow transfer, 32-degree denture teeth. And over the years, about a half dozen times, someone's come in and they've gone back several times and all this stuff. And I look at this 33-degree occlusion. I just walk it back to the lathe and go, smooth it all up, put it in their mouth, say, how's that feel? And they're like, oh my God, that's perfect. And then you look at the research, and 0-degree incline teeth are the most, the patients love them the most. And as the incline goes up, the patient satisfaction goes down. I mean, when I'm sitting at tables being a dentist for 54 years, people chew like cows. I mean, their jaws all over the place. They're not going up and down on a Danar articulator. They're, how some of these old men, when they're eating, food's falling out of their mouth, just like a cow. You know what I mean?
Well, for what it's worth, I spent 2 years taking the Roth course out in California, and the Roth course is a methodologically based orthodontic course of study, and I learned a ton about both the way I treat TMJ and the kind of occlusion that we try to set up. But I understand that that's an ideal, and you always want to shoot for the ideal. And if you don't get to the ideal, then you're at least getting to excellent. So we try to do that on a regular basis, removing any posterior interferences and balancing interferences and so forth. But if the patient is not a nocturnal bruxer, then the odds, how many minutes a day are your teeth together if you're not a nocturnal bruxer anyway, right? So that there's some wiggle room. The deal is that kids typically are more adaptable than adults, and so if you're trying to set up an occlusion that'll last them a lifetime, you want to get it as close as you can, as early as you can.
Dentistry is this year in America, the healthcare budget will come in at a first time ever past $3 trillion. And every year, 5% of it is dentistry. And I'm always most proud of dentistry because, I mean, what other profession has you come in every 6 months to see a hygienist or a nurse or whatever to try to prevent disease? I mean, we're the ones that have gotten fluoride in the water in 3 out of every 4 towns in America to prevent disease. I mean, we're always trying to put ourselves out of business. And one of the things that's most bizarre to me about orthodontics is, I keep reading papers from anthropologists that say, once you go back 400 years, you can't find a skull with a malocclusion. And then a lot of them have made these conjectures that, we went to a bottle, and then if they have, instead of nursing where it's, hard and the pressure's on their face, the food was tenacious and they had to chew it all. And now they've gone to a bottle. If they have a problem with the bottle, it's just right to a sippy cup. They're feeding them applesauce. When do you think the movement will really take off, where society will try to stop and say, well, wait a minute, why did nobody have malocclusions 400 years ago, all the way back to Lucy at 1.3 million years ago, and now everybody's got malocclusions everywhere? When do you think they're going to really start addressing that, about really preventing orthodontics by telling the mother, no, you're going to breastfeed your kid for 2 years, and if they're having difficulty, that difficulty is what's forming their face?
That's a really good question. There's a lot more to it than just that. Clearly, there's airway issues. There's genetic issues. There's clearly, I think that there are some environmental issues that are related to what you chew and how you chew. But but I don't think if you look back at paintings from before 400 years, there were people in the Spanish royal family who had class 3 malocclusions and prognathic mandibles. So I think that you can't blanket statement that it's too multifactorial, and I don't unless IBM comes up with a computer that can figure all that out. What is it, Watson?
Yeah.
If maybe Watson can figure it out. But I think that we should always be trying to put ourselves out of business, because our goal is to try to do what's best for the patient. Our goal is to try to take care of those patients as if we would take care of our own children or brothers or sisters or spouses. And if that's the best thing for them, that's what we should try to find out. I also think that in today's world, in the United States at least, trying to breastfeed a child for 2 years is completely unrealistic, because too many families are dual income families. And after watching my wife work full time while both of our kids were little, I know that trying to breastfeed for that long is damn near impossible.
Right. Lot of logistic issues.
Yeah.
You have done so much with cleft lip. Talking about what's going on with malocclusions. What is the cause of cleft lip?
I think that there's some of it's environmental, and some of it's genetic. I mean, if a patient has a cleft, there's a significant, I think that I'm trying to remember my statistics, but I think there's a 25% greater chance that one of their children will have a cleft. And if both parents have a cleft, there's a 75% greater chance that both kids will have a cleft.
But they haven't isolated the gene or the cause?
No. And it's superimposed on so many other different syndromes that it's hard to really be able to tell.
So what other things are associated with cleft palate?
There's some people that believe there's some nutritional things involved. I firmly believe that all the stuff that's in the air, I think that there are toxins in the air and in the soil, in the food we eat and things like that may play a part. Maybe not one specific thing, but one thing, adds on to another, and there you have it. And then there's some people that believe that, for example, a unilateral cleft is a more severe expression of a congenitally missing lateral incisor. So, it's so multifactorial. I don't think they really know for sure.
Huh. When you and I got out of school, this sleep apnea and obstructive sleep apnea, and I mean, I didn't get no one may have even mentioned it when I was in dental school, and I got out in '87. When did sleep apnea, obstructive sleep apnea, CPAPs? When did that enter your arena? And now it's just an explosion. There are some, like I say, hardcore people that say that if your patient bruxes, period. If they brux, clench, cline, you cannot make a night guard without getting a sleep study, because they think it's all related. How much are you getting into? What are your thoughts on all this sleep apnea?
Well, we're doing some sleep appliances, and we have, for example, I had a little patient the other day with a pretty recessive maxilla who had to go get a sleep study, and she's only 7. By the same token, I mean, we've always been, at least in my residency and from the way we taught it, we were taught at Baylor, looking for things like adenoid facies or the asthmatic appearance. You start to look for airway obstructions, and we know that the face grows differently based on blocked airways and so forth and so on. So we've been aware of it. We didn't really know how to solve it, and now I've had a number of patients over the years. We've had to do maxillomandibular advancements with orthodontics in conjunction with orthognathic surgery to prevent it or correct it. I sleep with an appliance myself to try to open up my airway and keep my wife from punching me in the ribs at night because I'm snoring so loud. So I'm aware of it. We're learning more and more all about it. In fact, about a year ago, the Southwestern Society of Orthodontics full program for 4 days was on sleep apnea and treatment and that kind of thing, diagnosis and treatment. So it's been about 10 years. Over the last 10 years, it's really become much more prevalent in the literature and in the continuing educations, and it's all a result of us aging baby boomers that are overweight and are not sleeping well.
I've noticed a lot of more and more papers are being published that treating sleep apnea with orthodontic surgery. How has orthodontic surgery been over for you the last 3 years? Is it about the same percent? Do you see yourself doing more of it in the last 10 years because of sleep apnea? Do you think that's do you think they're onto something?
Well, my practice has a lot of orthodontic surgery in it anyway because of the cleft patients that we have. By the same token, I think that most people are not really willing to do maxillomandibular advancements to stop their sleep apnea. They'd rather sleep with the CPAP. It's only when the CPAP fails and they have no other hope to be better that they'll do that, and understandably so. And the other thing too is that the insurance companies are cutting that kind of stuff out unless you've got a policy that will allow it for obstructive sleep apnea. You can't get it covered. So I would say we're probably not doing any more. A couple of cases a year is about all we see at this stage of the game.
Do you think that when people do not want to use a CPAP and their last straw is orthodontic surgery, are the results look promising?
They have. In fact, I had dinner with a ENT that's a sleep apnea expert, and he teaches and he's had a fellowship in sleep disordered breathing and surgery to repair it. And he said really right now there's two ways to effectively prevent or cure sleep apnea. One is a maxillomandibular advancement, and the other is like a pacemaker that goes in your tongue, so that if you're sleeping and your tongue falls back to block your airway, it gives it a tiny little shock that puts your tongue back in a more normal position. He said those are the only two things that are effective right now.
Well, I discovered a shot of Grey Goose right before you go to bed. We'll stop that every single time. Do you think I should do a study on that?
I think it'd be a great study. I'll volunteer.
You'll volunteer.
Although you got to promise me I don't get the placebo.
Well, we won't make it a double-blind study. So tell us about Smile for a Lifetime Foundation. When did you get into that? What got you into that?
We've been part of that for about 4 or 5 years now. Ben Burris, who you interviewed a while back, started this a number of years back, and there's now chapters in I think at least 40 states and at least two countries, and it's a great way for us to be able to give back. And it's unique in that it doesn't cost the patient anything except for a community service to help pay it forward while they're undergoing the treatment. So they've got skin in the game to try and improve somebody else's lot in life while they're getting the benefit of the pro bono orthodontic care.
And Ben Burris started that?
Yeah. And that's how I got into it, from knowing Ben.
Well, we could do a whole podcast on Ben.
Yeah.
He has that orthopundit.com. He is absolutely the most controversial orthodontist probably in the world. Who would even be a close second? Would there be one?
I can't think of anybody off the top of my head.
So what do you think of all those controversies?
Well, Ben and I have had this conversation personally, so I'm not saying anything out of school. I think the things that he wanted to do needed to be done. I think that the way Ben's very upfront and very he doesn't mix words, and he'll tell you he'll call him as he sees him, and to some people that's very off-putting, and so sometimes that can keep people from doing what you want them to do because they're not getting enough sugar, they're getting too much vinegar. But I think that, and in fact, the proof's in the pudding, though, because some of the things that Ben has advocated for over the last few years are beginning to change at the AAO level. And so I think, and they're good changes. It's going to be positive. So I think that.
And which changes are those?
Well, things like, let's say, for example, trying to cut some of the AAO's budget. Trying to change some of the ways that they do their continuing education at the annual meeting, trying to support orthodontists who are getting out of school or having a tough time because they're so far in debt and they're competing with everybody else in the world that's doing Invisalign and 6-month smiles and all that kind of stuff. So they're trying to provide support and help and education and so forth for those new and younger members who really need that help.
Well, let's talk about his most controversial, in my opinion, was when he thought the orthodontist should have a hygienist. I mean,
Well,
it's an access to care. I mean, if you the more point of entries, I think it's bizarre that you can go get your hair done, your nails done, but you can't get a cleaning unless you go to a dentist, and they're only open Monday through Thursday, 8 to 5. Even on a cruise ship in international water, I mean, you get a facial, a massage, a mani, a pedi. And I just walk in there, this boat's got 5,000 meals. I said, well, can I get my teeth cleaned? No. I mean, it's so what did you think about him thinking hygienists should work at orthodontist office?
I frankly thought that was fine.
Absolutely.
I didn't have a problem with that at all. I mean, because it's very hypocritical of a state to say to you, yes, you've gone to dental school. Yes, you've been through all those criteria. Yes, you've passed our state board. But because you have a specialty license, you can't do things that a general dentist can do. But on the flip side, the general dentist can practice any kind of dentistry they want to without any extra education, without any extra licensing, without any stricter controls or anything like that. I think the deal with the Arkansas State Board, he should have won that going away.
And there's basically Colorado's about the only place hygienists can have their own place. Isn't that the most part? The only one I think, and they only have like 7. And in their towns, they're small towns, and they'll take out their front room table and put in an operatory, and they'll clean because it's hard to pay overhead on a cleaning,
Right.
And people will come in and they'll get their teeth cleaned, and if she notices something, she writes a referral pad to send them to the dentist an hour up the road, and those guys love it. I mean, they just love it. Some patient calling up. Yeah, Susie just cleaned my teeth, and she wants you to check this spot. I mean, who could be against this? I mean, the patient has to come first, and access to care. I mean, this country's got 19,022 towns, and several thousand of them don't even have a hygienist.
Well, clearly part of the reason that the state dental board didn't want Ben to do what he was doing was because Ben was doing it on a big scale. He was advertising inexpensive hygiene, whereas the guy down the street that was a general practitioner had a hygiene. Ben was using hygiene as his loss leader to get orthodontic patients in, whereas flip side, the general dentistry using Invisalign as their loss leader to get general dental patients in. So, from a market standpoint, Ben was cutting into their business, and they didn't like it. But I think from a logical standpoint, it made plenty of sense to let people go where they want to go to get their teeth cleaned, or go to where they want to go to get their teeth straightened. And you shouldn't penalize a guy that's got a specialty degree to that expense.
Well, you mentioned the Arkansas State Board. Actually, your Texas State Board just did the most controversial thing of all, where the American Dental Association sued a guy who was advertising that he specialized in implants, and the
Right.
ADA said, no, we have 9 specialties, and that's not one of them. And he took it to the court, and the court said, well, the ADA it's a nonprofit club, and it's not a regulatory branch. And they said to this guy, do you only do implants? He said, yeah. And he said, then it's legal. And that has really changed the entire definition of a specialty. What are your thoughts on that, since you're living in the state where this is all going down?
Well, we hadn't seen the shakeout from it yet. Clearly, there are guys that's all they do, and I think there has to be some sort of regulation to that, because you can call yourself anything you want to, but until you can back it up with either credentials or education, you shouldn't be able to do that. For example, the lawyers have to have a certain license that they receive, or a certain certification that they receive to be able to say that they specialize in certain types of law. I think that they ought to have that same a similar kind of thing in dentistry. But whether it's the ADA that decides it, or whether it's a separate regulatory agency that decides it, I think clearly the courts have said it can't be the ADA. So that, and in the long run, that's probably a good thing, because that way it gets out. It becomes no longer a provincial or a local thing. It becomes a federal thing, and they make the decision about who can practice what.
Well, the thing I liked about the decision is every physician I know that's a friend of mine will tell me that if grandpa comes in and you say, okay, you need to go to a cardiologist and see this, and then you need to make an appointment at an endocrinologist and see this, and if he sends him to 5 different places, grandpa's going to walk out the front door and throw all the papers in the trash and go home. And the more convenient one-stop shop it is, and so many of these consumers, you know, oral surgeon or periodontist put in the implants, and they went somewhere else and got that, you know, the bridge or fix or removal on top, and it didn't work out right. Then they go back and they're just getting the runaround. And then when they find, here's a guy that can do A to Z. Come in here with your implant problem. I can place it. I can restore it. We'll just get her done. Come to me and I'll get her done. So, you know,
I can see that. The only difference I see in that analogy is that a physician right now, the reason that the physician has specialty licenses and specialty boards and so forth is so they can have the ability to practice in the hospitals, because the hospitals won't grant them privileges without those bona fides. And we don't have anything in dentistry that has any sort of relevance in that manner. So I think there's got to be some sort of separate regulatory, as much as I don't like that kind of, you know, big brother looking down your neck, but you got to have somebody that's making a decision with the patient's best interest in mind, and not have it be, you know, competing dentists making the decision or competing professionals making the decision.
Okay, explain that again about the physician specialty hospitals. That one flew over my head.
No. In order to practice in a hospital, okay, you have, if you're a specialist, you have to have your boards. You have, or any kind of physician for that matter, they have to pass both their specialty boards and then be approved by the board at the hospital. So there are credentials that you have to be able to do that, and as opposed to, or advertise as such. And in dentistry, we don't, you know, the ADA was the one that was making that decision, not the hospital board or the or a separate regulatory board. Does that make sense?
Yeah. Okay, so
Okay.
back to the podcast. Guys our age, we read dental textbooks and go to lectures. The millennials listen to podcasts. I mean, I swear to God, 95% of everyone that emails me is under 30 on this podcast. Only about one guy a month will send me an email and say, hey, I just want to tell you I'm an old fart and I listen to your show. What would you say? About 20% of these kids are in dental school. Some of them are working as an associate, and they're thinking about going back to school and being an orthodontist. What would you tell some kid listening to you right now as a junior or senior in dental school, or just been out a year or two, is thinking, I want to be an orthodontist, I want to be like Jeff Genecov? What would you say to them? Is that a good idea, bad idea?
I still think it's a good idea. I mean, there are people, there are guys that I don't know any orthodontists. Well, it's not fair to say, because I read the Facebook groups, and I read on Dental Town where guys are struggling. But overall, orthodontics is a great way to make a nice living and be able to do most of the things that you want to do. It's changing, though. I mean, they keep moving the cheese. Okay, I've been doing this 30 years, and the cheese has changed. I mean, it's a different flavor, it's a different color, and it's in a different place. But that's part of the challenge, is to continue to figure out how to do well by doing good, and how to keep your standard of living the way you want it, and not sacrifice or sacrifice your principles, and maintain your quality of care. But I still think with their education, as smart as they are, with the technology that they have at their fingertips, I still think it's a great way to make a living.
Couple more things. We were talking about implants, and I forgot to ask the implant question for you. When I was little, they had headgear, and now sometimes instead of headgear, they're placing a couple little implant tacks in the palate to get retention back. What is the incidence of headgear when you got out of school back in the day versus now? And are you using any of these little mini implants for retraction?
Always, often. Not so much for retraction, more for intrusion of the posterior teeth. Sometimes, like I have one patient now who's a child with autism, and he had a significant overjet that was disfiguring and crowded teeth. And so we put in implants because we knew he wasn't going to be able to wear elastics well or wear a headgear. But a headgear primarily is not really an orthodontic appliance or tooth moving appliance. It's an orthopedic appliance. It helps you control growth and development of the bones. So if you're trying, there are things that you can do with a headgear that we used to do with a headgear that we now can do with with TADs or other types of appliances, but it's not a complete replacement. But yeah, I use them every day.
Tads are how often
Mm-hmm.
use what's your instance?
Headgear, not so much anymore. I had one guy. You remember? Have you met Charlie Ruff from Maine? You know, he's on Orthotown quite a bit. And
Well,
Charlie Ruff,
I can't go on Orthotown.
oh, that's right. But
You have to be
he
an
was on Dentaltown.
orthodontist.
He was on Dentaltown for years and years as well. And Charlie's a really bright guy, and he teaches at Harvard. And he says, I use headgear a lot, but my patients not so often.
I think it's absolutely hilarious that I own Orthotown, and I'm not allowed to go on it. You have to be an orthodontist. That is an exclusive club you got there.
Oh, I mean,
You know the only thing I don't like about that rule, seriously, is I'm always running into people from Henry Schein Ortho, Kerr Orthodontics, orthodontic companies, and they always say the same great argument to me. And I understand. They said, okay, if all the orthodontists on Orthotown are all saying that they don't like our product because it's red and they all wish it was blue, if we don't know what they're saying, how do we make better orthodontic products for them? And I say, absolutely. Now, when I started Dentaltown in 1998, when dental manufacturers got on there, a lot of the dentists started complaining. They said, hey, get these guys off. They're trying to sell stuff. And I'd say, oh, so you're a volunteer? You just do free dentistry? Oh, you're some purist that money's evil? And I'd say, look, if you closed down 500 dental companies around the world, dentists would be sitting outside on a rug with stuff we bought at Home Depot, and we'd look like quacks. The only reason we look good is all this high technology, and the manufacturers, I believe, I own Dentist Town, but I called it Dental Town because I thought the manufacturers need to see what we were saying. But when I've suggested that to Ortho Town orthodontists, they just say no.
well, I can tell you that from their argument standpoint, and being on a number of different groups on Facebook, for example, and in other online forums and so forth, you can't get a consensus on anything. So they don't have to worry about everybody coming out and saying that something doesn't work or that they don't like the color of it or whatever, because that's not going to happen.
Yeah, whenever you're dealing with dentists, physicians, or lawyers, it's like herding cats.
It is.
Oh,
you get three of them in a room, you get 5 different opinions.
Oh, yeah. And TMJ is still the worst of all the subjects. I mean, that is the one that I'm ready to say that it's just a religion. It's there's no science about it. It's purely a religion. Would you go that far, or what do you?
Well, there's a lot of science to it because you have to know your anatomy and that kind of thing, so that you don't, unintentionally do something that's going to cause problems. But I think that there's, because the human body is so adaptable, that there's a lot of things that work. And so when you have somebody that sees it work once or twice or 3 times, all of a sudden it becomes something that works all the time.
Would you say that the orthodontist largest burr in their shoe, rock in their shoe under their foot, is retention issues? Is that just the lingering hangover the next morning? Does it give you the most pain in the rear?
It's retention and staff. I mean, if you're talking about clinically, then yes, I'd say that's probably right. If you're talking about a day-to-day, staff issues probably give more people headaches than anything else.
I agree that HR is the biggest issue in every company around the world.
Yeah.
And everything's management. I mean, everything's managing relationships, whether it's with your kids, your spouse, your staff. The people are the most complex. But back to retention. What works best for you as retention? Is it a fixed lingual bar? Is it removable retainers? Is it what's your secret sauce on retention?
Well, I like, myself personally, I like removable retainers for a number of different reasons. Primarily because you've had 2 years where you've asked the kid or the adult or however long they've been in braces, not to chew certain things, not to bite certain things, watch whatever it is that they're doing with their habits. You take the braces off and immediately you glue something in that you say, okay, well, there's something that's glued to your teeth now to keep them straight, but just like your braces, you have to be careful about biting ribs or eating fried chicken or, chewing nuts or whatever. So I don't think that's fair. By the same token, for some patients, that if that's what they insist upon, then I'll do it. But about once a week, we have patients come in, either that are our patients or others, that the dentist or the hygienist has knocked that lingual retainer off, and we have to put it back on.
And
So,
do you like the lingual? Do you think it's better when there's a flat fin on the back of the canines, and then a bar, or do you like the threaded wire where you put some bonding composite on each tooth?
well, certainly the single wire without bonding on each tooth is more hygienic. But if you had teeth that were rotated pretty severely to begin with, then Mother Nature has a pretty long memory, and she's going to want to move those back to where they were. So you have to look at where you started to try and figure out the best type of retention.
Yeah. So is there? I'm gonna get on my hands and knees and beg. Do you think there's any way you'd ever make online CE? And if you did, would it be for orthodontists on OrthoTown, or would it be for us low life general dentists on Dental Town?
Well, I would never call dentists low life because I had to be a dentist before I was an orthodontist, Howard. And some of my best friends are dentists. But I don't know where I could make the most impact and do the most good, and that would be something that I'd probably have to ask you to tell me what you think.
Well, I think the most important thing is these young kids or the moms saying, what's going on about the bite, just understanding early interception, answering mom's questions. What is a 6-year-old, a 7-year-old? You started the show with that these kids need to be seen by 7. I think you should explain why.
Okay.
I think you should get out there and say that this is what I'm looking for. This is what needs to be done. And then what happens if they don't see this? Because
Right.
here's the thing. Here's my belief. If a 25-year-old dentist just says, "Oh, Mom, you might want to go take little 6-year-old Megan or 7-year-old Megan to the orthodontist and have them get an exam," well, that's not a very good sales pitch. I mean,
Right.
you got to sit there and say why, and then
Right.
and be able to explain it, and then explain the carrot and the stick. Well, what happens if you don't? Blah 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 blah. And I think for me, I think dentists and physicians do the best when they get an A on the diagnosis and a C in the clinical. There's nothing worse than getting a C on the diagnosis and getting an A on the wrong treatment.
Right. Absolutely.
I'd rather you always get the A in diagnosis, and the rest you can get B's and C's.
Absolutely. I'd love to do that. It'll probably take me a while to kind of get it together, but I'd be happy to do that. I mean, I don't know.
Well,
I don't know what the process is, but
they say the guy in charge. I'm Howard at Dental Town. The other Howard
Right.
in charge of the CE is Howard Goldstein.
All
So
right, I
he's
know Howard.
Hogo
Right.
at foranmedia.com or dentaltown.com. And so you just email him or me or whatever. But we'd love because it's really hard to get ortho courses. It's a lot easier. But they say if you ever want to get anything done, give it to the busiest person you know, and you've got to be the busiest person I know. And I've been, really, you are a legend on OrthoTown. Hell, you have over 1,500 posts on OrthoTown, and I can't say that I've read any of them, or I'd be violating the terms and conditions of the agreement that I wrote and signed by myself.
On Dentaltown, though. I was a moderator on the Ortho deal in Dentaltown for a long time.
Yeah, are you still?
No, I think I brought in a new associate, and I scaled back some of my Dentaltown work, so I haven't been on as much. So Howard probably thought that I wasn't seeing as many of the things that needed to be addressed as need be. So I'm no longer. They dropped me.
Yeah, is that right? Okay.
Yeah.
Well,
yeah.
Hey, again, are you going to go to that? Are you going to be out here in Scottsdale for that Henry Schein Ortho Summit? I think in February.
I hadn't planned on it. I'm not. In fact, to tell you the truth, I'm not even aware of it. So I don't know.
Yeah, well, there's one in my backyard, and so I was thinking if you go to that, you have to call me up, and we'll go get a burger and a beer, and I'll show you why you should be a Cardinals fan.
Never happened.
I'll buy you an Arizona Cardinals shirt. How's that?
The closest I got to being a Cardinals fan was when Emmitt Smith went to play with the Cardinals.
Yeah.
And that didn't last. I mean, he was only there a couple of years. But,
and your greatest quarterback actually came from our Arizona State University.
Danny White?
Yeah.
No kidding.
Yeah, he's a friend of mine, and I run into him probably every other year, somewhere, somewhat, but just a class act guy, just an amazing man.
Sadly, he, but for 180 minutes, he could have been a Hall of Famer. He took the Cowboys to 3 NFC championships in a row, and unfortunately, they didn't win any of them. So he didn't get to play in a Super Bowl as a starting quarterback. And had he won either any of those three and won a title, he'd have been a Hall of Famer. He was that good.
Well, the greatest story, and if they ever made a movie about him, if you ever know the ASU story, is that their quarterback went down, and everybody was sad because they had to put in this backup guy named Danny White, and then he just went out there and just crushed it, and everybody's like, "Oh my God, we've had the wrong starter all the time," but no one knew it until the starter couldn't play anymore.
And he was a damn good punter too.
That's right. That's right.
You know, he was the punter for the Cowboys for a long time.
And he's just an all-around great guy.
Well, he's calling the Cowboy games for a network in Arizona, if I'm not mistaken.
Is that right?
I think he does either radio or TV for a network in Arizona now. Yeah.
But hey, I want to tell you seriously, thank you for all that you've done for Dental Town, for Ortho Town. I know you're busy. You just got done with the course, and you decided to spend an hour with me and my homies, and I just really, really appreciate it, and I think the world of you, and thank you so much.
It's been my pleasure, Howard. Thank you.
All right, have a great day.
You
Go
too.
Cardinals.
Great weekend. Go Cowboys.